Good evening everyone. I am Dr. Sandeep from Max Hospital, Vaishali. I am presenting the case of 36-year-old female resident of Ghaziabad. She is a housewife and patient is a known case of CKD 5 on peritoneal dialysis. Now presented with chief complaint of fever for 5 days, pain abdomen for 5 days and cloudy PD outflow for 5 days. History of present illness. I would like to date my history to 10 years back, when during her pregnancy in 3rd trimester on evaluation found to have proteins in urine, hypertension and raised serum creatinine. There was no history of edema, hematuria, there is no history of recurrent UTI or passing stone in urine, there is no history of fever, rash or joint pain.
This was during the pregnancy?
Yes ma'am. There was no history.
This was her first pregnancy?
Yes ma'am, this was her first pregnancy. There was no history of chronic use of painkillers. She was followed through the antenatal period and had full-term cesarean delivery.
When was the proteins found in the urine?
Yes, ma'am.
You have to tell us which part of the pregnancy, because you said she was...
Ma'am, in the 3rd trimester. When she was followed through the antenatal period and had full-term cesarean delivery due to obstetrical reasons, the indication was cord around the neck. She delivered a full-term healthy baby. Her post-operative period course was uneventful and she was discharged from hospital on POD 4 of cesarean.
During the entire period, was she conveyed like anything about her renal illness, hypertension, anything?
Ma'am, she got to know everything on evaluation during 3rd trimester of pregnancy only.
So she told that she had hypertension?
She told that doctor told her that she has high BP.
What medicines was she put on?
Ma'am, at that time she was put, she doesn't remember what medication she was put on.
But she was put on something for blood pressure?
During pregnancy, yes ma'am.
And this was continued post-pregnancy?
Ma'am, she was discharged.
Yes, okay, you can continue.
Ma'am, on her follow-up visit with her gynecologist, she was found to...
Obstetrician.
Obstetrician. She was found to have continued raised blood pressure, for which she was told to follow up with a physician. But the patient did not comply for the same and never consulted any physician and irregularly took her BP medication during these days. 4 years back, she started having complaint of increased fatigability, decreased appetite and decreased urine output. She consulted a physician for these complaints and on evaluation found to have raised serum creatinine of 7 mg per dl and shrunken kidneys. And she was referred to a nephrologist, where she was advised for a renal replacement therapy and she opted for peritoneal dialysis. The PD catheter was inserted laparoscopically and fluid exchanges were started after 14 days.
So going back to the history where she presented with proteinuria during pregnancy and then hypertension and nothing was done, what do you think was the basic disease during this time? What could have been the potential differential diagnosis for your diseases?
Ma'am, maybe chronic undiagnosed chronic glomerulonephritis.
Okay. Then what would
Why do you say it's chronic? That started in the 3rd trimester of the pregnancy. If you say it's chronic, it's at that time she wanted a diagnosis, not after 4 years. At that time, what would you be in your differential?
Ma'am,
she knew everything. She didn't know about ultrasound size at that time?
No ma'am.
So now tell us, what do you think would have been her diagnosis? You gave a history of somebody who was told to have proteins in the urine, had no edema, nothing, had blood pressure, was taking some medicines, isn't it? So what all history would you have taken to find out exactly, I mean, an idea of what was the kidney disease?
Ma'am, she might have reflex nephropathy.
How do you say it's reflux? Why do you say it's reflux? What is the clinical presentation of reflux? And during pregnancy, when she is antenatally followed, nobody noted her reflux?
Ma'am, in 3rd trimester of pregnancy, she might have preeclampsia.
No, you cannot just tell us. You have to tell what you think it is and How
What
important
is
is,
your,
yeah.
What is your supporting evidence for
Yes.
that diagnosis?
You don't have to tell us, and you have to tell if it was your patient at that time. You have a history and a disease which was, let's say, was not there in the first trimester. Obviously, it was not there because she wouldn't have conceived. She wouldn't have gone up to a complete pregnancy, isn't it? So it's a third trimester disease which resulted in a kidney function loss by 3 years or 4 years.
6 years.
6 years.
6 years, isn't it? Where you had no evidence of edema, even not during pregnancy, isn't it?
What? Just give us 3 differential diagnoses that you think that could be basically her basic disease.
Ma'am, chronic glomerulonephritis,
Okay.
ma'am, reflex nephropathy.
Why do you use the word reflux nephropathy also? What is the nephropathy in reflux? What if you had an opportunity to biopsy a reflux patient, what the biopsy will show? What is the word that you will use?
Ma'am, scarring.
Is there a reflux is some form of a very histopathological pattern. Scarring to you will see in DMSA. Biopsy may you may even miss scars, isn't it? कभी सोचा है? Have you ever seen, I mean, when you read something, primary FSGS, secondary FSGS, what are the diagnoses that comes in that secondary FSGS category?
Yes, ma'am, second FSGS due to reflex.
Yes, one of them is reflux, isn't it? So, you say reflux, and then the third one. Tell us what are the points in favor of reflux in a pregnant woman at third trimester, and what are the points in favor, I mean against?
Also, this proteinuria was never quantified, no?
Yes.
It was just, she was told there is some proteinuria. In pregnancy,
Yes, ma'am.
any kind of albuminuria is considered abnormal. You don't need 3 grams of proteinuria,
Proteinuria
right?
to say it's CGN,
To
isn't
say
it?
it's CGN. So, I mean, apart from glomerulonephritis, what other things do you feel?
Even in your clinical practice, can somebody with 6 years with a chronic glomerulonephritis be completely asymptomatic? Which kidney disease is predominantly asymptomatic? She was not troubled by a kidney disease, isn't it? So that means no Susan, no facial puffiness, no high blood pressure, no headache, nothing. Those are the manifestations of chronic GN. So she didn't have it for 6 years, isn't it?
Yes, ma'am.
She said that she had those symptoms and she sort of did not, she neglected them, or
Ma'am, she neglected them gradually.
the symptoms, or
What symptoms did she have for 6 years which were neglected?
Ma'am, not for exactly for 60 years, but she has increased fatigability,
those
decreased.
are uremic symptoms that
Yes,
can
ma'am.
happen with CIN. In fact, it's more common in CIN than in CGN. Why? You know why fatigability is more common in interstitial patients and all? You have to always think like that. Why is it important? She's how old is she now?
36.
So what madam saying, the first idea is what was the primary disease that you are dealing with. Always think of it. Now what was the points against reflux?
Ma'am, she has no symptoms like of she has no UTI or urinary symptoms in the past.
So and pregnancy is a infective, people have infection so much more. No? What percentage of pregnancy has urinary tract infection? Are you aware? What percentage of pregnancy has UTI, asymptomatic bacteriuria, acute pyelonephritis? सोचा है कभी?
If you get a patient in your third, considering she would have come to you with proteinuria and got a referral for her, what is the evaluation that you would have liked to do in a 26-year-old girl who has come with her first pregnancy and now has, what are the things from history, clinical examination and investigations that you would like to know about this patient to help to come to a particular diagnosis of what it is?
Yes, ma'am. Ma'am, she is a young lady. So, ma'am, we will first of all, ma'am, we will do a urine examination to look for, ma'am, proteinuria and, ma'am, active sediments if it presents. Then, ma'am, we will quantify the urine protein, and ma'am, then ma'am, we will rule out lupus nephritis because she is a young lady. We will do C3, C4, ANA, and
Directly. Before that, clinical examination, what things will you look for?
ma'am, we will look for malar rashes and
Not that we know. When somebody asks you, you're in the third trimester, we will do investigations looking for primary causes and secondary causes. Why do you only jump with lupus? What are the other diseases which a 26-year-old girl can have? Lady.
If she had proteinuria in your first, say, second trimester, okay, she was 22 weeks pregnant, and you don't know what it is, what are the normal tests that you do to know what is the underlying causes? Clinical examination. What I'm trying to ask is, how do you know that this is not a pre-existing illness which has presented in pregnancy? She happened to have detected. She has a history of missing her medicines and not being very compliant. It's possible that might be a pre-existing illness which was detected during pregnancy versus a fresh onset new disease which was picked up in the third trimester.
Yes,
so were there any tests done before or later, or how do you differentiate this is not some chronic disease which is ongoing? Some 2-3 findings that you would look for.
ma'am, anemia.
Anemia is in pregnancy also.
Ma'am,
Okay, what are the features of chronic hypertension that you would look for in somebody if you want to see?
ma'am, hypertensive retinopathy.
Okay, you can do fundus examination then.
Ma'am, LVH.
Cardiac examination,
Yes, ma'am.
maybe, yes. You can take history of any chronic headaches, any blurring of visions, which
Yes.
you generally take for hypertension. If you're talking about anemia, which was severe enough, was there any history of blood transfusion before the actual admission?
No, ma'am,
or
she
pregnancy?
didn't give any history of.
Okay, then you can go for your secondary causes, and secondary causes you can ask for. Why lupus only? Then you can think of all the secondary causes and start talking about it. Okay, chalo.
And is it important? She's 26. She's from Ghaziabad. Is it important when she got married and when she conceived? Delay in conception, that history always has to be there. It took her 5 years to conceive, or 4 years to conceive, or she conceived within 1 year. That's not important. Sometimes we have many other reasons. But an underlying chronic kidney disease will delay your conception and all. No? And there was no edema. That she was 100% sure. And she never had edema throughout her...
No, ma'am, she don't have edema during pregnancy.
What percentage of pregnancy has edema? A normal obstetric person.
Ma'am,
You have to justify, no? So, and this next question is, if she just had hypertension without proteinuria, will you call it as pregnancy-induced preeclampsia, the word that you use?
No, ma'am.
nowadays? So the proteinuria was just told to her, never quantified, never checked before, afterwards.
Okay.
Next.
When PD catheter was inserted laparoscopically and fluid exchanges were started after 14 days. She was advised with 3 exchanges at the starting. She was advised with 3 exchanges per day of 1.5% 2 liter bags.
Can I stop you for 2 seconds? Can you give me a little more history on terms of when she presented? What was her clinical status?
Fatigability, uremic symptoms.
Uremic symptoms.
Yes,
What
ma'am.
was the urine output at that point of time? What were the comorbidities that were there?
Yes, ma'am. Ma'am, she presented with increased fatigability, decreased appetite, decreased urine output, and ma'am, she doesn't tell how much urine output she was producing at that time, but she said that she was decreased.
She is your patient from the beginning when you
No, ma'am. No, ma'am.
initiated? So did she at least know what were the parameters besides creatinine at that time? She doesn't remember.
No, ma'am.
Was any blood transfusion given?
Ma'am, no.
Did she have a lot of cramps? Any special calcium supplementation was given or told to her or something like that?
No, ma'am. Ma'am, she was advised for antihypertensive medication like amlodipine, but she didn't take that.
Continue.
Ma'am, she was advised with 3 exchanges per day of 1.5% 2-liter bags. Caregiver was her husband and father-in-law.
How do you sort of describe the PD exchanges? You said 2 liters, 1.5. Something else? 3 exchanges?
Ma'am, 3 exchanges.
Any other parameter that you look into the PD prescription?
Ma'am, duration.
That is important. How many hours?
All for 4 hours.
All 4 hours continuously, night dry, all that you have to tell us now. It's so important to see, was she ever dry in the night?
Ma'am, she is taking all the prescription during daytime and night with the night dry.
Night dry.
Yes, ma'am.
So how much was the ultrafiltration? That much she will tell you?
Ma'am, presently she...
No, not that one. The presently ultrafiltration is fallacious. We are not even...
Ma'am, at that time she was exactly not knowing, like it was around 500 to 600 ml.
With all 3, 1.5%?
Yes, ma'am.
And how was her volume status with that much? She was... Were there any signs, clinical signs?
Ma'am, this was initial prescription.
Okay.
But on repeat visit to her nephrologist.
When was that?
Yes, ma'am.
After how many days?
Ma'am, after 1 month she visited.
Why do we use that word 1 month? Is there any reason to call the patient after 1 month? Why not before? We never thought of it. Why just we tell them you do this basic standard prescription of 1.5% 4 hours 3 times and come back after 1 month? Any reason? Is that important or what is important? How will you tell your patient, I have started PD, it is 1.5%, you do 4 hours, घर चले जाओ 1 महीने में आ जाओ, ऐसे बोलोगे या what will you tell the patient to follow up?
Ma'am, we will tell her to, if the symptom does not improve,
what symptoms are you asking for?
Ma'am, uremia.
Uremia की तो नहीं बात होता है ना, तो what are the fatigability was the only thing. When you start PD, what is your biggest concern compared to hemodialysis?
Ma'am, adherence to the prescription.
Fluid balance. So the first thing you will ask the patient, how do you feel? Check your weight. Are you gaining weight progressively? Is your edema worsening? That's the first thing. 1 month nahi bologe. Do your PD, see how you are doing, how much you are draining, that you will look. But predominantly you should ask, are you progressively gaining weight? And is your edema or whatever worsening? Why is that important?
Ma'am, because ma'am, if edema is there, we will change the prescription.
1. And what do you achieve in the first 1 month? What do you want the patient to be? With whatever prescription, duration, everything? You want to achieve euvolemia, isn't it? Why do you need that? Did this patient had any other assessment for the peritoneum?
No, ma'am.
Nothing. So she was just started, चलते रहो 1 महीना आया. After 1 month, what happened?
Ma'am, after 1 month, she was after 1 month she was put on 1 2.5 liter 2.5% bag and 3 1.5.
4 exchanges she went into.
Duration of exchanges?
Ma'am, 4 hours.
तो अभी तो 16 hours हो गया. That means you are only...
Ma'am, no, ma'am.
16 तो नहीं होगा, और भी होगा, because 20 minutes to do the exchange पर. 17.
Ma'am, 1 exchange was like 12 hours.
So 12 hours, what percentage? What was 12 hours?
Ma'am, 2 bags of 1.5% and 1 bag of 2.5%.
12 hours. Do you know the fallacy of what this prescription is?
You're saying 2 of 4 hours each and then 1 of 12 hours?
No, ma'am. Each is for 4 hours. 1 bag is 2.5% and 2 bags are 1.5%.
So let's get it clear. 3 exchanges.
Yes, ma'am.
3 bags.
Yes, ma'am.
2 for 1.5%.
1.2 Ma'am, initially,
अभी बोलो, last वाला बोलो, because you just have to clarify.
ma'am, 2 bags of 1.5% for 4 hours duration and 1 bag of 2.5% for 4 hour duration.
बस यही है.
Yes, ma'am.
3 bags.
3 bags.
So there is nothing for 12 hours.
No, nothing for 12 hours. Ma'am, and on.
As a question, if it was 12 hours, what percentage would have been that bag?
Ma'am, I could explain.
Isn't it?
Ma'am, on other follow up, ma'am, that gradually increased over the 4 years to 4 exchanges at present per day with 2 bags of 1.5% and 2 bags of 2.5%.
Now tell me what has happened to this peritoneum over these 4 years.
Ma'am,
would you have done something to understand what do you think is the transport character of this peritoneum? Can you make out from a bag what is the transport characteristic of the peritoneum? हम लोग शुरू करते हैं PD.
Yes, ma'am.
But we should at least have an idea what peritoneum are we dealing with, no?
What test do you do to know the transport status?
Ma'am, we do PET test to know the transport.
हुआ था इसका? Yes, the PET was done for her?
No, ma'am, PET test was not done.
So if you don't do PET, is there a way you can find out what is the transport characteristics? What company bag she is using?
Ma'am, Baxter.
Go online, there is a book of Baxter. You can peritoneal membrane test. All you need is to put your exchanges and how much is the UF. It immediately tells you what kind of you even don't have to do PET. PET is not required nowadays, but you need to understand the peritoneum. What do you think was the peritoneum of this person? With this kind of prescription that you think, what would have been this peritoneum?
Ma'am, she is fast transporter, ma'am.
Fast transporter, 4 hours. If she was a slow transporter, what would have happened to her?
Ma'am,
if you do 4 hours in a slow transporter, what happens to the patient?
Ma'am, in slow transporter.
Yes.
Ma'am,
Somebody who is a slow transporter and you're doing 4 hours of an exchange, what will happen to the patient clinically?
Ma'am, reabsorption of the fluid.
No, the solutes will not be cleared. The patient will become uremic.
Yes.
Because you need 6 hours to clear the solutes. The other way, if she was a slow transporter and you're doing 4 hours of it, if she was a fast transporter and you're doing 6 hours of exchange,
ultrafiltration will not happen.
Yes. So that is something you have to understand. One causes fluid retention, the other causes reduced solid. So she would have become much more uremic. So she didn't do it. She was clinically fine.
Yes, ma'am.
This you can do with Baxter. PET is not required. If PET is not required, what you should have done for her, what a test you should do if she was not doing well, let's say. The PET membrane characteristics tells you about your ultrafiltration. If you're not filtering much, you can go to that Baxter book. It is there. I still have it. You can download it and put it and then say, nahi ho raha hai. But then let's say the patient is not doing well as far as uremia is concerned. She's developing symptoms. What would you have done? Along with PET, what else is done?
Ma'am, tests.
Do you know what is the software which Baxter has for the PET?
Ma'am?
What is the software Baxter has for PET?
Ma'am,
what is it called? Anyone?
Something, ma'am. It is for automated.
Adequest. PD Adequest. Why is that word PD Adequest? Because what does it do?
It is questionnaire.
It looks at the adequacy of your PD. So if you forget the transport characters, you can tinker around with changing the time, changing the percentage, you will get reasonable good ultrafiltration. But if you're sitting with a patient with 18 creatinine, what's the point doing PD? The PET, that bag that you take out, overnight bag and the 4-hour bag, actually is used to calculate creatinine clearance and get a K2 reading. So now what is the creatinine clearance that you calculate in PD?
Ma'am, how will we calculate KT upon V?
What is the
target that needs to be
creatinine
achieved?
clearance, and do you achieve daily creatinine clearance
Ma'am,
or weekly clearance?
Ma'am, target KT upon V is 1.7 and creatinine
What, in one day or
per week.
per week? And the creatinine clearance?
This is, ma'am, is 45.
65. These things you should know, because when you do PD, if you don't see patients, if you see more patients, you will see how challenging and difficult it is to do PD. ठीक, next. Next, madam. And it has moved from 3 exchanges to 4 exchanges. So what has happened?
Ma'am, membrane dysfunction.
Membrane has become much more faster. It has become much more, because you are not being able to remove the fluids.
Yes, ma'am.
So it might have been a high average to a high transport. Isn't it?
Yes, ma'am.
So batao, the next. So after that, now you come to
Move on with your case.
Move on to your case.
Yes, ma'am. Ma'am, 4 days back, patient started having fever, which was around
So in this 4 years, you have never had any episode of
No,
infection?
ma'am, she has no.
Do you think it is good? Is it the target that ISPD wants you to have for a single patient? Have you ever looked at the individual target for PD and PD peritonitis and institutional target for PD peritonitis?
Does anyone know what is the ISPD target?
What is the target? If my patient is on PD, how many peritonitis episodes you would have allowed this patient who is on PD for 4 years? If it is, that's how you will know that this patient is not doing well. Anybody? You are supposed to know the most today amongst all of us, no? What is the PD peritonitis rates which are accepted as by the ISPD guidelines? Which should a good institution should have one episode in how many months?
One month.
Every month you will have peritonitis? Masti Any idea? What is our, where is the maximum PD done in India? Centers where we do PD. What is our Indian data? Any idea? PD peritonitis rates now? Yeah, everybody has to know this, because if there is a PD, there is a case. Isn't it?
This is a short case,
Sure,
either a
whatever
long
the
or
reason,
short case.
PD even with catheter kinked or whatever they will give. So you cannot miss it, because you don't see patients does not mean you will not. All of you will read. Maximum work on PD is from SGPJ. They have a lot of published data. Even All India Institute has papers. CMC Vellore has. Some of those Bombay centers have. One episode in 24 months is acceptable. That is, one patient, if your patient has not had a EA for 2 months, you have done, 2 years, you have done well. So in 4 years, she should have had 2. That means she's done well, isn't it? So that's one thing. So she's got it now. Now comes the question, why did this happen in a patient after 4 years?
Ma'am, maybe due to faulty technique.
What is faulty technique?
Who was doing the PD till now?
Ma'am, her husband and father-in-law.
Is that acceptable? You can allow 5 people to do the PD to the patient?
Ma'am, because her husband is not all the time at home.
So why was she not encouraged to do it?
Ma'am, she is taking help from them.
So as madam asked, is it acceptable? You should have not more than one person doing the PD. Isn't it? The more you do. So who was doing at that time?
Ma'am, they both.
No. When in the last few days, did you get the history should come now. You cannot just use the word faulty technique. You have to find out why this happened. Yeah, what is the faulty technique?
What is it that you're...
So what do you think is the commonest faulty technique that happens? PD exchange देखा है तुमने करते हुए?
Yes, ma'am.
What is the commonest? What are the types of techniques? Faulty techniques देखा है? Where are the areas in PD, as far as you are saying techniques, which you can identify that things can go wrong?
Ma'am,
First, number one,
ma'am, hand hygiene.
hand washing. Two,
Ma'am, after wearing gloves, ma'am,
nobody wears. Is PD a sterile technique? So why are we wearing gloves? PD is a clean technique, not a sterile technique. You don't have to wear gloves. You should understand that. This is very clear. So you should not say after wearing gloves means क्या पेन हो निकलो पहने निकलो gloves तो पहनते ही नहीं है कोई. Have you seen them do it? No.
yes, ma'am.
Gloves पहन के करते हैं.
Ma'am, yes, ma'am.
Then next, after hand hygiene, then next.
Next, ma'am, connection.
Connection के पहले क्या करते हैं? What is the other thing that we do before we connect?
Ma'am, opening the.
First check the bag. Sometimes we use expired bags.
Yes, ma'am.
So that is the next thing that we look is the bag
Ma'am,
quality.
check the bag
fluid.
leakage in any leakage in the bag.
वो कैसे पता चलता है?
Ma'am,
How do you know there is a leakage?
ma'am, to physically see the bag.
उसमें से पकड़ के ऊपर से टप 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 ड्रॉप्स हो रहे देखते हो क्या तुम?
Ma'am, any bubble in the bag.
Bubble क्या है? Bag should never have bubbles. No, these are sterile, aseptic. You don't have bubbles. How do you inspect a bag? Ask those PD trainers to come and show you. How do you inspect the bag? What are the things you look into the bag?
Ma'am, any. Ma'am, this any leakage.
First you look at the expiry. Next, what do you look at? You don't look at the. You hold the bag, press it like this, then you see leaks. Third,
Ma'am, turbidity.
turbidity कैसे? Fluid में turbidity कैसे देखते हो? These are all
What are the
practical
techniques
questions.
that you do?
How do you say that the bag is turbid?
Ma'am, we put it over the newspaper and.
ये तो बोलना ही है. You should be able to read the newspaper.
Yes, ma'am.
Okay. You saw the bag. Then what do you do after seeing the bag? What are these bags? What connections they have?
Ma'am, they have.
What are this connectology called? These bags that you have.
Ma'am, Y connection.
Y set, because
Y
these
set.
are Y connections.
Yes, ma'am.
Earlierly they used to be O sets. So some examiner who are very old, they will have seen. So you hang the bag. Then what do you do?
Then when we hang the bag and after we opening the mini cap and we
Do you open the mini cap and open it completely? एकदम खोल देते हो और fluid निकल आता है.
no, ma'am.
So you just open the mini cap, but you don't open the flange.
No.
So the transfer set is connected.
Yes, ma'am.
If you open that by mistake, what is this called?
This is called, ma'am, wet contamination.
Vent contamination. What is dry contamination?
Ma'am, any contamination outside the closed system is.
When you touch when the systems are dry.
Yes, ma'am.
So you then open the mini cap, then you connect it. Then
Yes,
what
ma'am.
do you do?
Then, ma'am, we will 10
10 नहीं 10 count करने बोलते हैं वो लोग. But that's what do you call this? What is this technique called? It's called flush before fill,
full.
isn't
Yes,
it?
ma'am.
And then the whole system is filled up, there is no bubble there.
Yes, ma'am.
Then you open and the drainage happens.
Yes, ma'am.
If it is a full bag, isn't it? And then you, after the drainage has completely happened into the Y bag or the extra bag, then you fill the fluid and then close it.
Ma'am, then we from the bag we will discard some.
That's called flush before fill.
Yes, ma'am.
It's not called discard. The whole tubings of the Y set are filled
ma'am.
with fluid. You are flushing it out. No gas, no air bubbles or anything.
Yes, ma'am.
Then you will drain. Always you drain first, isn't
Yes,
it?
ma'am.
Whatever the residual fluid, whatever. And then you fill.
Yes, ma'am.
So where do you think should you be taking this history to find out where could have been a faulty technique? This is very important. Why? Why is it important to get this history from the people who are doing this, the caregiver or the patient?
Ma'am, to prevent the repeated infection.
So this helps you retrain a patient. Whenever they say, how do you treat peritonitis? The last thing after antibiotics, biotics, everything. The idea is to retrain, always retrain the patient. So you have to, if you're going to retrain, you should know what's gone wrong with them, isn't it? Then ask something about
Case.
case one.
Ma'am, 4 days back, patient started having fever, which was around 101 degree Fahrenheit, continuous and relieved by taking medication. Patient also complained of pain, abdomen that was diffuse, and there was no aggravating or relieving factors. Also, there was a cloudy outflow from the PD catheter, which she says was like a rice water. There was no history of redness of PD fluid. There is no history of redness or discharge from the exit site. There was no history of loose stool or constipation. There was no history of burning micturition. There is no history of recent invasive procedure or gynecological procedure.
Continue.
She presented to
One thing you miss is the tunnel. You maintain redness and discharge from the
exit site.
exit side.
Yes, ma'am.
Tunnel, did you mention? You to, what is a tunnel infection defined as? All across the tunnel or any part of the tunnel, or even a little bit of the tunnel is a tunnel infection?
Ma'am, redness with the purulent erythema and discharge from the exit site.
and tenderness.
Yes, ma'am.
In duration. At what length? From how much? The whole tunnel or any segment? Any segment will be tunnel infection. Define tunnel infection, in fact. There is a definition for this also. Next.
Ma'am, she presented to emergency room where she was admitted, and after sending relevant investigation and PD fluid culture, she was started on empirical antibiotics along with other supportive measures. CAPD was continued during the hospital stay, and patient clinically improved with treatment, and she was discharged on intraperitoneal medications.
So the moment she came to you, you sent all the cultures and all. What was the report of that?
Ma'am, culture was negative.
Culture was negative.
Yes, ma'am.
And counts? Do you have those reports?
Yes, ma'am. Ma'am,
how do you define CAPD peritonitis? What are the things that you need to?
Ma'am, according to ma'am ISPD criteria, one of the two criteria are required. First is ma'am clinical.
One of the two.
One of the three. Two of the three. Ma'am, first is ma'am clinical cloudy, effluent and pain abdomen. Second is ma'am PD effluent TLC count more than 100, with neutrophils more than 50 after minimum of 2 hour indwell. And ma'am third is culture.
Indwell matlab kya hai? What do you mean by indwell?
Ma'am,
she came to your hospital, you drained it. So what do you mean by indwell? Did you ask her kitne der rakha tha pet mein?
Ma'am,
when did she come?
Ma'am,
What time did
she
come?
came early morning.
So that time she was dry, no?
Yes, ma'am.
So how did you send the PD?
Ma'am, we have to fill the bag.
How much?
Ma'am,
If your abdomen is dry and you have a patient with abdominal pain, vomiting and a history of cloudy effluent of the 5 days, last 5 days, how do you send the PD fluid for culture? And this is a dry abdomen, no?
Yes, ma'am.
Will you just drain that and send it?
No, ma'am.
So then how do you do that?
Ma'am, we will fill
How much of volume?
Ma'am, 2 liters.
No, there is a technique for that. You have to fill for 1 liter, keep it for 2 hours and then send it for culture. The same question again is asked. There's all examiners we ask, what if you had got the bag of the night and sent it for culture? Could you have done that?
Ma'am, we can.
Can you instruct your patients ki, theek hai, raat ko she must have finished in the night and she came in the morning because she was symptomatic.
Yes, ma'am.
So she would have drained in the night, no? Why not that bag? Why didn't she could have got that bag, no? We could have sent, we shouldn't have waited this 2 hours of filling it and then waiting and sending. So, could she have bought that bag and given it to you for culture?
Ma'am, but then there is a chance of.
Is there a way you could have instructed them to? Many a times we say, no, ki say you drain something and then you see it's cloudy and you know your hospital laboratories are not open. How do you manage that? You can keep the refrigerate that back at some temperature, bring it and take it for culture. So it prevents all this morning aake 2 ghanta wait kar. And how do you culture? Next question. Do you send any advisory to your lab that this is PD fluid and this has to be cultured? How do you culture PD fluid?
Ma'am, we sent the sample in a blood culture bottle.
Backtake or whatever.
Yes, ma'am.
And if there is no blood culture bottles with you, then how many mLs of blood culture volume, PD volume, and what PD volume will you send? कैसे करते हो?
Ma'am, 5 to 10 ml.
The bag has to be shaken nicely.
Yes, ma'am.
And then 5 to 10
5 to 10 ml in the 2 culture bottles are sent.
And then as she said it is negative, after 3 days what do?
Yes, ma'am.
Your blood culture was, your PD culture was negative. You sent for blood culture. 3 days back it is come negative.
Yes, ma'am.
What will you do?
Ma'am, it depends on the clinical condition of the patient. If the patient is improving.
No, there is nothing to do with clinical condition. The ISPD guideline is every effort should be made to get a culture positive peritonitis. The rate of your culture negative peritonitis in your hospital should be less than
15 to 20%.
20%, less than that. So what will you do, tell your microbiology, to improve the yield of your culture?
Ma'am, centrifuge the sample.
No, get that blood culture bottle, get the fluid, plate it in a solid media, thioglycolate or agar or something. Then you may grow something. Centrifuge kab karte hain? What is the other way of centrifuging? Now that you say centrifuge. When you don't have blood culture bottles in your emergency, how do you send for centrifuge? You have asked, you have to answer, because these are standard questions any examiner will ask. Padlo, read up. Huh? It is to be sent, there is a specific way of 3 to 5 ml, centrifuge at 3000 G for I think 15 minutes, resuspended in 15 ml, 3 to 5 ml of buffer. If you have Narayan Prasad, he will ask you the names of the buffer. And then that 5 ml has to be cultured in the blood culture bottle. Isn't it? You should know the buffer also. So you understand? Take 3 to 5 ml, centrifuge it, 3000 for 15 minutes. The pellet is formed. Take that pellet, resuspend it in 5 ml of 3 to 5 ml of a buffer, and then send for culture in the backtake again.
Yes, ma'am.
The 5 ml that you were taking before, you can do this. Any other ways you can do any cultures? I mean, improve your culture rate. And nowadays, is there any new? There is a lot of data on faster and easier way of culturing PD fluid. Padhe ho?
PCR.
Theory questions. PCR, polymerase chain reactions for various. These are good for gram positive. And what else? I've written it here. What is Malditoff? These are questions will be asked for PD. What is Malditoff? Okay. Even I forget. But someone, any one of you? You people see PD patients? No, no? अभी पूछो, मैंने बहुत पूछ लिया, तुम पूछो। Antibiotics. She said intraperitoneal.
So basically, how would you have monitored this patient? You said that she was admitted in the hospital. Do all PD peritonitis patients need to be admitted in the hospital firstly?
Yes, that's a question initially. When
Yes,
you say that emergency, when the patient came in emergency, one history you have to give in, did she have hypotension or not? That's a very important parameter you should have told.
Yes, ma'am.
Ma'am, आया PD में करके घर चला गया.
Yes, ma'am.
Isn't it?
Ma'am,
as she is asking, do all PD patients need to be admitted?
No, ma'am. Clinically stable patients can be managed at home also. She can be managed at home, but because she came to emergency, we have admitted her.
This is like very policy. Yeah, and you should have admitted her in ICU. I think that's the only thing.
But you, according to you, she was hemodynamically stable.
She was hemodynamically stable.
Okay, and then after that, the culture was negative. So how did you look for improvement in your?
Ma'am, on third day we sent repeated TLC, and that was in decreasing trend, and neutrophils were also in the decreasing trend, and patient was clinically improving. So ma'am, we discharged her on the.
So how many days of PD? I mean, antibiotics you have told her to continue now?
Ma'am, for 14 days.
What antibiotics is she on?
Ma'am, she was on vancomycin and amikacin.
Intraperitoneal कैसे दे रहे हो vancomycin? She is doing now, she is going to do 4 exchanges. So all 4 exchanges will have IP.
Ma'am, in one exchange.
And amikacin?
What is the duration that you have to keep it for? She's doing 4-hour exchanges,
Yes,
no?
ma'am.
So then how are you going to give it to her?
Ma'am, for the 4 hours.
Is that the recommended time duration for intermittent IP
Ma'am, for
antibiotics?
recommended is 6 hours.
6 hours, yes.
What is the dose for vancomycin?
Ma'am, vancomycin is 15 to 30 milligram per kg.
Every?
Every 5 to 6 days.
So that is for either you will have to give it to every bag, no?
Yes, ma'am.
Are you going to give every bag every day, or IP how do you give?
Ma'am, single bag in a single day.
Yes.
And what is the, generally what is the most common type of organisms found worldwide, and what is the data from India?
Ma'am, most commonly ma'am, is skin infection, like gram positive organism.
Which
Like?
one? Which
Staph
one?
epidermis.
Okay,
Where? In India?
What is the
in
data
India?
from India?
Data from India you should read. It's predominantly gram negative. Predominantly gram negative. Our data. So you give vancomycin and amikacin, you should check again. What is the difference between a gram negative CAPD peritonitis and a gram positive CAPD peritonitis?
Ma'am, gram negative is difficult to treat.
So what should you have done for this patient? Would you have told her to come back after 14 days, or you would have asked to see a TC again once?
Ma'am, we have asked her to come after 7 days.
Is there any psychological number which we do, which day we do to say this is improving or not improving? In ISPD guidelines, 5th day you are supposed to do the count, and if it's worsening,
Yes, ma'am.
one of the indications of removing the catheter, especially in culture negative.
Yes, ma'am.
Isn't it?
What are the indications for removing a catheter in a CAPD patient?
Ma'am, fungal peritonitis, recurrent peritonitis.
What is recurring peritonitis?
Yes, ma'am.
What is it recurrent or the relapsing one which you remove the catheter?
Ma'am, for both.
Both there is one you have to remove, the other you can do without.
What is the
What is
definition?
relapsing and recurrent? Yeah, definitions.
Ma'am, recurrent is, ma'am, after treating a peritoneal episode, within 4 weeks, if the ma'am.
Within 4 weeks will be relapsing, no?
Yes, ma'am. Ma'am, both are within 4 weeks, recurrent with the same organism and relapsing with a different organism.
In this case, you got a gram negative culture. So now, if she comes back within 4 weeks, what would you call it?
Within 4 weeks with a different organism.
How do you know? You got a gram negative. You
got
got a culture negative patient,
ma'am.
na?
So how will you know?
So how will you know? If she comes back after 4 weeks and she has a peritonitis episode again, what will you classify her as?
Ma'am, relapsing.
Relapsing, right? You assume it is the same organism.
That's
Right.
why you believe it is. And if the next time also you don't get culture negative, what are the other organisms you should be thinking of?
Ma'am, mycobacteria.
In India it's very common, no? Fastidious organisms.
Yes, ma'am.
Mycobacterium tuberculosis has to be thought of. And other indications of catheter removal?
Ma'am, recurrent repeat peritonitis.
Now you have to define what is repeat peritonitis.
Ma'am, repeat peritonitis is, ma'am, after treating an episode, after 4 weeks is called repeat peritonitis.
Any other indication which you have to remove a catheter?
Ma'am, GI infection, like, ma'am, GI infection.
They are not GI infections.
Secondary peritonitis.
Secondary
you mean?
peritonitis, they call cholecystitis, pancreatitis, viscous perforation.
Yes, ma'am.
Those are different. Tunnel infection is an indication of removing a catheter because it doesn't go unless you remove the catheter.
Yes,
Any other organisms in which the guidelines have so-called recommended removal? The
ma'am,
catheter.
pseudomonas.
And? In gram positive?
One organism they have asked to remove. I mean, they have recommended.
In gram positive,
If you have MRSA infections or VRE infections, in those cases also they
Also they
recommend
have.
to remove the catheter.
And
But if-
Malditoff is actually used for VRE and MRSA. It helps you grow those organisms. I mean, identify them faster.
what are the other differential diagnoses for cloudy cloudy effluence?
ma'am, it can be eosinophilia, eosinophilic,
Eosinophilia is the eosinophils in the blood.
eosinophilic hemoperitoneum.
What is eosinophilic peritonitis?
Ma'am, because of any reason, if there is increased eosinophils in the PD fluid.
What are the causes of increased eosinophils in the PD fluid?
Then
So
parasitic.
an allergy, no? Allergic reaction.
Yes, ma'am, allergy.
There was a time when there was a batch of PD, when we were in Bombay, a batch of Baxter bags had huge eosinophilic peritonitis. So there was some chemical contamination.
Yes, ma'am.
Is there any drug which causes eosinophilic peritonitis, which we commonly use? This again will be asked. Some common drugs in our practice can cause eosinophilic peritonitis.
Calcium channel blocker.
Yes, of which is the most important calcium channel blocker which can cause? Pablo, you have read so much, you can tell all this, no? There will be. Chalo, any other cause of cloudy peritonitis?
Ma'am, hemoperitoneum.
Hemoperitoneum?
Ma'am, chylus.
Chylus. I have a kid with now chylus peritonitis.
Yes, ma'am.
Any more?
Ma'am, fibrins.
Fibrin should not become that cloudy, but yes.
Yes, ma'am.
Dry abdomen or fibrin in your malignancies,
Yes, malignancies
lymphomas,
can cause
lymphatic
all those,
blocks.
what is that called, pseudotumor, the ovarian malignancies and all, they can all cause that. Anybody else wants to?
So in this case you gave what all antibiotics?
Ma'am, vancomycin and amikacin.
Is there a new guideline related to amikacin and ISPD, which what have they recommended when
Ma'am,
you're giving amikacin?
Ma'am, for gram negative.
No, she is very clear. Should you be using amikacin regularly?
No, ma'am. Ideally, we should use amikacin in the patient whose urine output is less than 100 per day.
Why?
Because, ma'am, it is, ma'am, nephrotoxic.
No, there is something else. What is the word you use in nephrotoxicity? In PD. So, as she is saying, certain things should not be done in a PD patient because they have residual renal function. We should not take it away.
Yes, ma'am.
So, there are guidelines for amikacin now. So, should you have used amikacin for this patient?
Ma'am, she has 400 ml urine output, so.
So, then you should not have used it. No?
Why was amikacin chosen? Is there a local culture like in
PD
your?
का तो कोई होगा भी नहीं.
हाँ,
Why not some cephalosporin which could have been given to her?
Ma'am, we can give cefotaxime.
See, if you then the next final, if you have a patient who is not responding, and you believe there is peritonitis is bad, everything has to be IP. Can you give injections IV also? Not necessarily everything has to be IP, no. So, which drugs would you prefer as IV rather than IP?
IV, ma'am. Ma'am, for
Carbapenems, how do you give? IP or IV? Ask, people will ask you. If you need a meropenem to be given for your peritonitis, you believe there is a cholecystitis, quite common. They have a gallstone, they develop a cholecystitis and then they develop peritonitis. And I had a child now, the child had patent processus vaginalis. PD, fuck, everything came out in he had inguinal hernia. We closed it and he developed peritonitis. So it's a post-op peritonitis. So we need to give meropenem. So in that situation, what will you do, IV or IP?
ma'am, IV. For the sick patient, we will give IV.
How do you manage the fluid during this? In this case, you are saying the urine output was 400 ml, right?
Which is reasonable.
Which is quite good. So anyway, Amika Sen, I don't know if was the right choice, but for whatever reason it was given. Apart from that, what are the other things that you look clinically at this patient during an episode of peritonitis? One is she goes into sepsis and you manage the antibiotics. Secondly, during peritonitis,
ma'am.
what are the
sepsis, as she's saying?
worsening sepsis is one thing. Secondly, related to PD, what are the other things that you will monitor in this patient? And what are the changes in prescription that you are going to do?
Ma'am, we will monitor the ultrafiltration.
What will happen, do you think, now?
Ma'am, ultrafiltration will decrease.
Yes.
So you might
She's
need
already
to
going
change.
on to high
Yes, ma'am.
FPs.
You might need to change it. Okay. Anything else?
Okay. The other questions they will ask you is PET, so nobody asks, but it's good to know about PET. You can do without PET. Adequacy, somebody will ask. Types of ultrafiltration failure, that they will ask you. Your patient is on PD for 4 years almost. So they will ask you, what are the types of, if this is the one who has had peritonitis and her ultrafiltration comes down, what type of ultrafiltration failure is this?
Ma'am, fast PSTR.
No. Their names, type 1, type 2, type 3, type 4. So which category she will fall?
Type 1.
Type 1. All of you please, he's presented very well. You all should, PD will be asked. And I think the DNB pattern is the same, no?
Yes.
You know 500, 4 cases, 50 marks, 50 marks. No, 200 marks, 200 marks, 200 marks or something like that. It was 50 or 200 it was.
4 long cases, 4 short cases, plus
cases.
spots and questions.
4 long cases, so this will always be there. That's all.
Okay. Thank you.
Thanks.